Hi, my name is Melissa Murphy, and I am an infectious disease physician at the VA in Portland. I'm the HIV lead clinician for the Portland VA, as well as VA Vision 20, which encompasses Washington, Oregon, and Idaho. And I'm the medical director for the Oregon AIDS Education Training Center. And today, on behalf of the Oregon AETC, I'm going to be speaking with all of you about HIV post-exposure prophylaxis, also known as PEP. I have no conflicts of interest or relationships to disclose. So post-exposure prophylaxis, or PEP, is the use of therapeutic agents to prevent infection following exposure to a pathogen. High-risk exposures are grouped into either occupational or non-occupational. And this is what I'm going to focus on today. Occupational is divided into needlestick or other injury that pierces the skin or draws blood, or less frequently, contact with another person's blood or other bodily fluids through an open cut or through the eyes, nose, or mouth. Non-occupational post-exposure prophylaxis exposures include unprotected anal or vaginal sex with a known or likely HIV-positive partner, sexual assault, which is your focus, and lastly, injection drug use with a shared or used needle. So I'm going to start with occupational post-exposure prophylaxis, largely because most of the data that we have on PEP comes from occupational PEP, and most of the data that I'm going to go over you can extrapolate to non-occupational post-exposure prophylaxis, which I know you'll be dealing with more. But it's good to go through the historical perspective. So this is the timeline for PEP in the United States. So if you look here, the CDC actually didn't recommend using zidovudine or AZT for PEP until 1996. So AZT or zidovudine was approved for the treatment of HIV in 1987. But there was a lag time between its approval and its recommended use for post-exposure prophylaxis. Although in 1990, the CDC did suggest considering using it for post-exposure prophylaxis. So in 1997, there was a case control study that demonstrated that AZT post-exposure prophylaxis reduced HIV transmission risk by 81%. Then in 1998, so the subsequent year, the CDC put out its first major recommendations for risk-based, so 2-drug, which was the basic post-exposure prophylaxis, versus 3-drug, which was the expanded regimen for higher risk post-exposure prophylaxis, which actually created a fair amount of confusion around that time point as to whether one should use basic or expanded. So we fortunately don't do risk-based post-exposure prophylaxis anymore. And part of the reason we were able to do this in 1998 with these combinations was, bear in mind that HAART, or highly active antiretroviral therapy for HIV, became available in 1996 widely with the use of the protease inhibitors. The widely used protease inhibitor indinavir was actually FDA approved in 1996, allowing for just more than the single AZT to be utilized as part of this process. Then in 2001, the CDC issued guidance for occupational exposures to hepatitis C and hepatitis B, as well as HIV. In 2005, the CDC updated its basic and expanded regimen options for post-exposure prophylaxis to include some of the more widely used and newer agents that were available in the 2000s. And it was at that time that they also came out with treatment guidelines for non-occupational post-exposure prophylaxis. Most recently, in 2013, the CDC recommended using 3-drug integrase inhibitor-based regimen when post-exposure prophylaxis was indicated. And this is because in 2007, integrase inhibitors were approved for use in HIV, and they were not available at the time the 2005 guidelines were done, and are largely one of the best tolerated in terms of the antiretroviral classes, particularly in the short term, which is what post-exposure prophylaxis is. And as I mentioned before, it was with these latest iteration of the guidelines that the CDC got rid of these basic versus expanded regimens for post-exposure prophylaxis, which, as I said, caused a lot of confusion. So the current recommendations for post-exposure prophylaxis are what we're using from 2013. But you'll see a little bit of, in the history of that, just the AZT, for example. So this particular graph shows the number of confirmed cases of occupationally acquired HIV in the United States from 1985 to 2013. And as I mentioned in the previous slide, it was the CDC recommending the use of zidovudine or AZT for PEP in 1996. So you see that this did make a significant difference in terms of the number of confirmed cases of occupationally acquired HIV in the United States. And they have been, fortunately, few and far between since this recommendation was made. Now, if you look at the data for occupational exposure to HIV, and this CDC data is from 1985 to 2001, there were 57 confirmed HIV seroconversions in healthcare workers after occupational exposure to HIV, with an additional 138 cases of possible transmission in which HIV infection occurred in workers with no known risk factors for HIV infection other than the occupational exposure. Now, if you look at the who these patients were, these early cases of transmission of HIV to healthcare workers, the poor nurses fared the worst in that they had the majority of cases, 24 of the confirmed cases and 35 of the possible cases. And if you look at the specific routes of exposure, by far in occupational post-exposure prophylaxis, the majority are percutaneous, so puncture or cut injury. In this 48 out of the 57, with only a very small minority, 5 being mucocutaneous. And we do get a fair number of calls about these, but they do make up the minority of cases of HIV transmission risk. And when you look at the source of the exposure, by far the majority in these cases were blood or visibly bloody fluid. And these other random ones were like people working in the laboratory there. So when you look at the risk of HIV transmission following a percutaneous needle stick exposure, the pooled analysis of prospective studies on healthcare workers with occupational exposure suggests that the risk is approximately 0.3%. So fortunately, relatively low, but they have demonstrated that presence or absence of key factors may influence the risk in the individual exposures. And some of these include how deep the injury is. So if it's a very deep injury, it increases the odds for seroconversion. If the device is visibly bloody, it increases the odds. If the device was actually in an artery or a vein, it increases the odds. Or if the source patient was terminally ill, it increases the odds. So you'll see that the odds ratio for patients who received AZT as post-exposure prophylaxis significantly reduced the likelihood for seroconversion in this study. And again, this is an older study from 1997 because fortunately, as time has gone by, we've had less and less of these conversions. Other factors that influence the risk are the viral load of the source patient. Fortunately, now with our antiretroviral therapy, patients with HIV have, in most cases, very well-controlled HIV viremia. So if the viral load is undetectable, the source patient is unlikely to transmit HIV to another individual. And that's important when we talk about non-occupational post-exposure prophylaxis, when you consider the issue of undetectable equals untransmittable. So if the source patient has a viral load less than 200 copies per milliliter of blood, they are unlikely to transmit HIV to another individual through sexual intercourse. Glove use in occupational exposures, 50% decrease in the volume of blood transmitted in folks who are wearing their gloves. Hollow bore versus solid bore needles. So the large diameter needles are weakly associated with an increased risk. And drying conditions. So there is a 10-fold drop in infectivity every 9 hours. So when we look at all exposure risks, and these are combining the occupational and non-occupational exposures. As I mentioned, the percutaneous or blood is actually on the lower end at 0.3%, with mucocutaneous being 0.09%. Now, the sexual risk factors are obviously much higher. And you'll notice that the highest risk is in receptive anal intercourse with a rate of 1 to 2%. So this is the receiving partner is the HIV negative partner. And some studies have demonstrated this to be as high as 10% with factors such as illicit drug use, particularly with methamphetamines, which contribute to rougher sex playing a role in this. So this is basically related to the trauma of the tissue. So you're having semen to blood, which is why in the case of insertive anal intercourse, the risk is much lower. Receptive vaginal intercourse, again, 1/10 of the risk of receptive anal intercourse, and insertive vaginal intercourse, the least. And if we talk about injection drug use needle sharing, it's 0.67%, and vertical prophylaxis, or vertical with no prophylaxis, obviously quite high. So this is why we always want to be doing HIV testings as part of routine obstetrics. So the relative risk of infectious fluids in occupational exposure to HIV. So if you look at the specific fluids, as I mentioned before, blood is most likely to be the source in occupational exposures. So blood or visibly bloody body fluids are considered infectious. Potentially infectious include semen and vaginal secretions, cerebrospinal fluid, synovial fluid, pleural fluid, peritoneal fluid, pericardial fluid, and amniotic fluid. But not considered infectious unless they're visibly bloody are saliva, vomitus, and feces, nasal secretions and sputum, sweat, tears, and urine. And we do get questions about these from time to time. So just remember that these particular fluids do not typically transmit HIV infection unless they are visibly contaminated with blood. So the next question is, when should post-exposure prophylaxis be started? So it makes logical sense that the risks of PEP are going to remain constant over time, but unfortunately, the benefits of PEP decrease with time. And there's no clear point at which PEP is no longer worth it, but there are some suggestions based on the window of opportunity. So 24 hours after virus acquisition, HIV can be found in antigen-presenting cells translocating across the mucosa. By 48 to 72 hours, HIV can be found in regional lymph nodes. And at 5 days, HIV viremia is detectable in the blood. So if somebody is contacting you on Thursday afternoon about a potential exposure that occurred on Friday night or Saturday night, it is actually too late to be considering post-exposure prophylaxis, because realistically, after you get to this point, as I like to say, the horse is out of the barn. It's really just too late to have a significant impact. So the best study that we have with regard to the effectiveness of post-exposure prophylaxis, that's not simply a case control study, but rather a prospective study, was done using Tenofovir, the TDF version of Tenofovir in macaques. So in this particular study, there were 24 macaques that were randomized to 6 treatment arms and received inoculations of simian immunodeficiency virus at 10 times the 50% infective dose. And they were started on post-exposure prophylaxis with Tenofovir at either 24, 48, or 72 hours. And this was continued for either 3, 10, or 28 days. Now, if you look at the data from this, let's look at the 2 extremes first. So not surprisingly, the placebo, those macaques that received no Tenofovir post-exposure prophylaxis, had 100% simian immunodeficiency virus infection. On the other extreme are the macaques that started their post-exposure prophylaxis with Tenofovir at 24 hours and were given that post-exposure prophylaxis for a full 28 days. So in that case, 0 of the macaques developed the simian immunodeficiency virus. So this is the equivalent of HIV, but for monkeys. So then if you look at the distinction, it appears based on the other data that the starting at 24 hours was actually more important than the duration of therapy, because you see that in this particular arm, where the post-exposure prophylaxis with tenofovir was started at 24 hours and continued for just 10 days, only 25% of the macaques developed infection, versus if it was continued for the whole 28 days, but not started until 48 or 72 hours, that number was higher at 50%. So again, this data suggests that the most important thing is actually to start at 24 hours. This is the particular study where we get our duration of 28 days of treatment for PEP. So the general core principles of post-exposure prophylaxis are always in every single individual patient, balancing the risk versus the benefits. And the timing is very key. The sooner you start it, the better. So my advice is always to just simply make a decision, because PEP can always be discontinued, but you can't ever get those first 24 hours back. So just remember, there are some situations for which expert consultation is advised. And frankly, I think if you're stuck trying to decide, you're kind of on the fence as to whether post-exposure prophylaxis should be prescribed, it's very reasonable to get a second opinion from another individual who's been doing this and prescribed PEP fairly frequently. And so again, some of these examples would include if it's longer than 72 hours, if you're not sure what the source was, if the person is pregnant or breastfeeding. And I would say if you have somebody where the source patient is known to be HIV positive and they have antiretroviral resistance, or you're particularly concerned about toxicity of the PEP regimen, those are instances where you should definitely discuss the case with someone who has HIV expertise. And in the case of someone with suspected antiretroviral drug resistance, ideally the HIV provider of the source patient, so they can help tailor the post-exposure prophylaxis regimen for that specific patient. And this applies both to occupational and non-occupational post-exposure prophylaxis. So the baseline and follow-up for occupational post-exposure prophylaxis. So first off, you want to, and we're going to talk about what therapies to start in the next section, but you want to reevaluate the patient within the 72 hours, just make sure they're doing okay on therapy. And then for baseline and follow-up testing, you want to get an HIV test at baseline, and then HIV testing at 6 and 16 weeks if you're using the 4th generation assay, which I think most of us are now. And again, the 4th generation assay is the combination of an HIV P24 antigen and an HIV antibody test. If you have the older generation, which does not include the HIV P24 antigen, then you're doing it at 6, 12, and 24 weeks after exposure. You also want to get baseline and follow-up lab testings of the kidney and liver function at baseline and at 2 weeks, because one of the medications that we prescribe, the NRTI combo, is metabolized through the kidney, and the integrase inhibitor is metabolized through the liver. So I just want to make sure everybody is aware of the HIV test times to positivity. It's important when you're prescribing post-exposure prophylaxis and also getting a good history, if you have a patient who has a high-risk exposure, to understand which is the appropriate test to order. So in this particular graph, you'll see HIV infection is at time 0. The HIV RNA, which is in the plasma, starts to increase, and it can be detected at day 11. The HIV P24 antigen can be detected on mean day 17, versus the antibody test is not available or is not detectable until day 22. So again, this is why I was commenting the distinction between the 4th and the 3rd generation test. So the 4th generation test has both of these things, the P24 antigen and the HIV antibody. So you'll see that it's going to turn positive a little sooner after HIV infection than the older version. But I would caution you, if you have a patient that you're concerned may have acute HIV infection, the appropriate test to order is the HIV PCR. So this is HIV RNA PCR up here. And just to review the signs and symptoms of primary HIV infection, and HIV primary infection is symptomatic in the majority of newly infected individuals. These symptoms occur about 2 to 6 weeks after the exposure to HIV, and the median duration of symptoms is about 15 to 28 days. And it's this prolonged duration that distinguishes the acute retroviral syndrome or primary HIV infection from other more mundane viral upper respiratory tract infections, because sometimes the symptoms are very overlapping. Because if you look at the symptoms that you see in primary HIV infection, you see these in a significant number of other viral infections. So fever, lymphadenopathy, pharyngitis, myalgias, arthralgias, you see those quite frequently. So it's really the duration when somebody's been ill for quite a long time. The rash that we associate with acute HIV infection is sometimes very subtle, and it's particularly difficult to see on people that have darker skin. So this oftentimes is not helpful, even though they list it at 70%. And I would just mention that every once in a while, you will see acute HIV infection as a cause for aseptic meningitis, and occasionally some other very unusual neurologic symptoms like a Guillain-Barré syndrome or a mononeuritis multiplex in the minority of cases. And it's important to be able to recognize primary HIV infection if you're following somebody who is on post-exposure prophylaxis and they're coming in with symptoms. They may be worried that they're having the symptoms of acute HIV infection, whereas they may have something totally unrelated, viral upper respiratory tract infection, COVID-19, or they could be having a side effect from the medication. So it's important to understand the timing of when these symptoms would occur and the symptoms that you would expect to see with primary HIV infection. So I'm going to switch to non-occupational post-exposure prophylaxis now. I want to start with why this is very important and how you all play a significant role in non-occupational post-exposure prophylaxis. So in one study of rural emergency departments in one particular state, 54% were offered STD prophylaxis treatment of sexual assault patients, which, as you know, all these numbers should be higher, but they get worse. 18% had no sexual assault protocols in place. 13% offered on-site HIV testing only, and only 9% offered non-occupational post-exposure prophylaxis. So we have a lot of work to do in making sure that providers who are seeing patients on the front line particularly after sexual assaults or traumas or high-risk encounters, are aware that non-occupational post-exposure can be prescribed. So the common reason that providers give for not prescribing non-occupational post-exposure prophylaxis is the concern of drug side effects. The folks, they really are concerned. They're like, these are drugs with significant side effects. These are your drugs, not our drugs. We don't prescribe these routinely. But you have to remember, a lot of the people who are feeling that way, their main thought process when they think of antiretroviral therapy are things like AZT, which was approved in the 1980s and had significant GI side effects. And AZT plus 3-TC plus indinavir was the first recommended post-exposure prophylaxis regimen, and it wasn't well tolerated, but the newer regimens are much, much better tolerated. Another concern is for drug resistance. There's a potential risk of drug resistance with poor nPEP adherence and HIV exposure, but that's very low. Perception that the exposure that the person's coming in with is a low risk, and that's not always the case. No or limited health insurance, or simply some people have just lack knowledge about the nPEP guidelines. So I want to review the exposure risk algorithm for nPEP with all of you. So the first thing you want to look at is this a substantial or a negligible exposure risk? So when we look at that, when we're talking about a substantial risk for HIV exposure, you're talking about exposure of the vagina, rectum, eye, mouth, or other mucous membrane, non-intact skin, or percutaneous contact with blood, semen, vaginal secretions, rectal secretions, breast milk, or any body fluid that is visibly contaminated with blood when the source patient is known to be HIV infected. So that is a substantial exposure risk. A negligible exposure risk would be if one of these specific sites was exposed to urine, nasal secretions, saliva, sweat, or tears if they're not visibly contaminated with blood, because as we talked about, these particular things are not infectious for HIV. So in this case, the status, the HIV status of the suspected source patient is irrelevant if the fluid is not something that transmits HIV. So if the exposure is considered to be negligible, then nPEP is not recommended. Then the next thing you look at is how long has it been since the exposure? So if it's been more than 72 hours since the exposure, nPEP is not recommended. But now if we're at a substantial exposure risk and it's less than or equal to 72 hours since the exposure, then the next thing you're going to look at is whether or not the source patient is known to be HIV positive. If the source patient is known to be HIV positive, you definitely want to prescribe nPEP. If the source patient, their HIV status is unknown, then it's going to be on a case-by-case determination. And in most of those cases, I tend to err on the side of caution of prescribing the post-exposure prophylaxis, because as I said before, with occupational post-exposure prophylaxis, you can always stop PEP. You can gather all the information that you need and then decide, oh, the source patient doesn't have HIV. We've documented this. Or the source patient has HIV, but they've had an undetectable viral load for the last 15 years, and we just got back that their viral load at the time of the exposure was undetectable. So there are different things to take into account when you're making these decisions, but I would encourage you, if you're on the fence and you're not sure, go ahead and start PEP and then try and get more information to inform your final decision, but you can never go back in time to get those first 24 hours back. So the nPEP treatment guidelines, which are also what we use for occupational post-exposure prophylaxis, are going to be the combination of tenofovir, usually in its TDF form, which is the tenofovir disoproxyl fumarate, with emtricitabine in the combination that is known as Truvada, with its brand name, plus an integrase inhibitor, either raltegravir, which is dosed 400 milligrams twice a day, or dolutegravir, which is dosed 50 milligrams once a day. And a lot of people ask me, well, how do you decide which one of these two to use? I've used both of these medications in HIV patients extensively. I would say the advantage of raltegravir over dolutegravir is there are less drug-drug interactions because this drug is metabolized through glucuronidation, and it generally has a little bit less in terms of GI side effects, but it's not a huge difference. The main benefit of the dolutegravir over the raltegravir, as you can see, it's once a day dosing, which increases the patient's ability to be adherent with the medication. There's also a cost issue. Usually the dolutegravir is more expensive, at least at our facility. But either one of these is a completely reasonable option. Whichever one the patient's going to take and whichever one you can get is perfectly reasonable. So when we look at those medications, just a reminder that when we're combining those two combinations, so tenofovir and emtricitabine are nucleoside reverse transcriptase inhibitors. So they work at this specific spot in HIV replication where the HIV RNA goes to DNA. And this DNA is typically integrated into the CD4 cell nucleus. And it is at this site that the integrase inhibitors work. So what you're doing, these particular combinations, this specific combination is one of the first line regimens that we use for people who do have HIV. So you're giving combination antiretroviral therapy, 3 drugs that work at 2 different sites. And this is why this works well. So some of the key concepts, just to summarize for providers, are that you want to evaluate persons rapidly for nPEP when care is sought less than or equal to 72 hours after a potential exposure. Do an HIV test before initiating nPEP. So if rapid testing is not available, send the blood to the lab and just go ahead and initiate the nPEP immediately, and follow up with the results. So remember, as I said, if the patient did have HIV, what you're starting them on for nPEP is actually a first-line antiretroviral regimen. So there's no worries on that front. And then all persons offered nPEP should be prescribed a 28-day course of the 3-drug antiretroviral regimen, but please try and make sure that they get that first dose on site ASAP after the exposure, because that first dose is very critical. A lot of times we've seen patients who have been discharged from the emergency room with a prescription to go and fill PEP. They get to the pharmacy and find that the copay is astronomical and they just give up, and then they never get it. And then by the time they get things sorted out in terms of getting the medication paid for, time has passed and they're past that 72-hour mark. So our institution has devised little PEP packs in the emergency room. So most places will do either 3 days or 5 days worth of medications. Those are key in making sure that the patient gets started on their post-exposure prophylaxis as soon after the exposure as possible, while you're getting sorted out how they'll get the rest of their prescriptions. So those are key. Adherence to recommended dosing for 28 days without interruption is essential. You want to emphasize that severe adverse effects from nPEP are rare, but review the possible side effects and reinforce the limitedness of such side effects. So I always tell patients when I prescribe that particular combination of tenofovir emtricitabine with an integrase inhibitor, that they are going to have potentially, at least in the first few days, maybe a little bit of upset stomach, a little bit loose stools, but nothing horribly significant. Sometimes patients will get some headaches with that as well, but by far, those usually last just a few days. So we try and encourage people to just write it out. But I always tell people that, you know, we have a plethora of options in terms of antiretroviral therapy. So if somebody has an unusual reaction from one particular medication, we can consider doing drug for drug substitutions. I would encourage you, if that happens, to touch base with somebody who is a routine prescriber of HIV meds to help figure out what would be the best drug to substitute. But I have to say that very seldom happens. Patients worry about it all the time, but now that we're no longer using the combination of AZT with a protease inhibitor, we're using the Truvada with an integrase inhibitor, the nPEP and occupational PEP are very, very well tolerated. And lastly, make sure that you go ahead and arrange for a follow-up appointment with the patient for additional counseling and monitoring, and make sure that they have contact information so that they can have all their questions answered, because they don't always think about those right when they're in the emergency room. So there are clinician-to-clinician assistance options for PEP-related questions. So there's the AATC National Clinician Consultation Center for our post-exposure prophylaxis, the general PEP line, which you can also have the perinatal HIV hotline. The warm line is utilized for patients who already have HIV. So there are a lot of options out there. Just if you want to touch base with another provider about, first of all, deciding what you want to, whether or not you want to put that patient on PEP, whether PEP is indicated. And secondly, if you're concerned about the specific regimen or anything, just to touch base with another provider. And lastly, I wanted to just remind everybody to refer nPEP patients for discussion about initiation of PrEP. And I think there's going to be a separate lecture for all of you on PrEP, but I'm just going to give you a quick overview. So what is PrEP? So PrEP is pre-exposure prophylaxis. We've been talking about post-exposure prophylaxis, but pre-exposure prophylaxis is a prevention strategy in which individuals at highest risk of HIV infection take a medication regularly, along with continued behavioral risk reduction strategies to prevent HIV infection. So Truvada, which I've just mentioned is a component of PEP, was approved for HIV PrEP by the FDA in July 2012. and is a fixed dose combination of tenofovir and emtricitabine. And I will comment, in the infectious disease clinic at the VA, if we have one of our ER staff that starts a patient on non-occupational post-exposure prophylaxis, or nPEP, we try and get that patient scheduled into our clinic before their 28 days are up, so that we can, first of all, make sure that all of the appropriate labs were done and that they're doing okay. But a lot of times, if the risks that brought them into the emergency room for their non-occupational post-exposure prophylaxis are going to be continuing, we'll transition those folks right from post-exposure prophylaxis to PrEP, which essentially is when we verify that their HIV status is still negative, we simply continue the Truvada for PrEP alone. So who are these people who should be offered PrEP? So you want to consider offering PrEP to individuals who have a sex partner with HIV or HIV risk factors, condomless vaginal or anal sex with a partner of unknown HIV status who's known to be at substantial risk of HIV infection. If a patient comes in with one sexually transmitted infection, for example, gonorrhea, chlamydia, or syphilis, then most of those individuals are also at risk for HIV. If the patients inject drugs or share needles or equipment, and then this is specifically in the CDC guidelines, if they've used non-occupational PEP within the 72 hours. So that's a key point to remember. So you always want to ask about when their high risk exposure was. So when we see people for PrEP, that's the consult, we'll sometimes actually start them on PEP because of the high risk exposure and the timing of that, and then transition them to PrEP if they do not, which, knock on wood, we haven't had anybody seroconvert. Survival, transactional sex, and I will comment that research studies do suggest that men or transgender individuals engaging in receptive anal sex benefit the most from PrEP. And again, that's, as I mentioned to you before, the anal receptive intercourse is the highest risk of HIV transmission because you're going from semen to blood. So when we start people on PrEP, the key messages in terms of efficacy are that when it is taken daily with excellent adherence, PrEP is over 90% effective for preventing HIV. So if you have a patient who's interested in potentially going from PEP to PrEP, go ahead and send them to someone who does PrEP, because we're always happy to chat with patients and go over the risks and benefits of continuing on PrEP. Not every single patient that I see that's been on PEP decides to go on PrEP, because sometimes the nPEP exposure was a single isolated incident, but it's always good to have the conversation, and it's always good to have the opportunity to educate these patients when they are coming in after a high risk exposure. So another point to remember with regard to PrEP is that maximum drug levels are reached in rectal tissues after 7 days and in blood and vaginal tissues after 20 days. And if planning to stop PrEP, patients continue them for 28 days after the last potential HIV exposure. But PrEP does not prevent gonorrhea, chlamydia, syphilis, genital warts, herpes, or hepatitis C. And so I am going to stop there. And I think this may be when it goes live. So I'm hoping that I'll have the opportunity to answer any questions that all of you have on this particular topic. And if you have any specific questions for me after reviewing this, you can send an email to me if you hop on the AETC website, if you have specific consultation questions as well. Thank you.